presented by Dr. Amina Tara Santos.
Society of Women in Orthopedic Surgery set of lectures. This year, we will be discussing on how postmenopausal osteoporosis and osteoporotic bone fractures were managed during the ongoing COVID-19 pandemic. Our lecturers are experts in the respective chosen subspecialties. Our first speaker, Dr. Maria Felmarayel, had her residency training at the Philippine Orthopaedic Center. She took 2 fellowship programs, one as an orthopedic oncology fellow at the University of Hong Kong, and the other as a hand and microsurgery fellow in the Nagato General Hospital in Japan. Our second speaker, Dr. Anne Kathleen Ganal Antonio, is a present trustee of the Philippine Orthopaedic Association. She had her orthopedic surgery training at the Philippine General Hospital and took her spine surgery fellowship training at the Duchess of Kent Children's Hospital, the University of Hong Kong. She's currently the head of the spine section of the orthopedic department at the Quirino Memorial Medical Center and is affiliated with a number of hospitals in Metro Manila. Dr. Ana Rosario Santa Ana Famador completed her residency training at the Makati Medical Center and took her spine surgery fellowship at the Singapore General Hospital. She is currently a consultant in the Makati Medical Center, Department of Orthopedic Surgery. Our last speaker, Dr. Dayan F. Pangilinan Docena, completed her orthopedic surgery residency at the St. Luke's Medical Center. She then subspecialized in joint replacement and sports medicine at the Christ Hospital of Cincinnati in Ohio, USA. She currently practices in Pampanga and is a medical specialist at the Jose B. Lingad Memorial General Hospital. We shall now proceed to our lectures. Let us reserve our questions at the end of the first 3 lectures, or you may type your questions in the chat box. Without much further ado, we shall begin with our lectures.
I'm Dr. Riel from Bicol Medical Center, and today I will be discussing about postmenopausal osteoporosis, to treat or not to treat. I have no disclosures. This is the outline of my talk. Bone mass increases during childhood and adolescence, peaking at the 3rd decade of life. It declines steadily in both sexes afterwards. In women, however, a rapid decline in bone density is seen in the early years following menopause. Osteoporosis is a skeletal disease characterized by low bone mass and structural deterioration of bone tissue. This compromises the bone strength, predisposing an individual to an increased risk of fracture. The estrogen deficiency contributes to a rapid decline in bone density through increased cytokine production, which stimulates bone resorption via osteoclastic activity. This leads to cortical thinning, increased porosity, and trabeculate destruction. The prevalence of postmenopausal osteoporosis in the Philippines is around 19.8%. The presence of a fragility fracture is the single most important manifestation of postmenopausal osteoporosis. These are low-energy injuries such as a fall from standing position to the hip, spine, proximal humerus, and distal radius. Postmenopausal women have a 50% increased risk of fracture versus men at more than 50 years of age. 20 to 25% of mortality is seen within the first year following a hip fracture, secondary to a cardiovascular or pulmonary complication. Aside from estrogen deficiency, other bone loss factors include conditions with elevated parathyroid and thyroid hormones, nutritional deficiencies with calcium, vitamin D, and protein, immobilization via production of sclerostin, and toxic causes such as excessive alcohol intake and cigarette smoking. Clinical assessment starts with history and physical examination. This includes a history of fragility fracture after 50 years of age and assessing for the following risk factors: Secondary causes of osteoporosis, height loss of kyphosis, and fall risk factors are also important to assess. Screening is recommended for the following: all postmenopausal women, premenopausal women with a history of fragility fracture or secondary causes of osteoporosis, and those with premature ovarian insufficiency not using estrogen. This can be achieved by requesting for a dual energy X-ray absorptiometry or a DEXA scan, which measures the bone density in specific sites such as the total hip, the femoral neck, the lumbar spine, and the distal radius. Based on bone density scan, the WHO has classified the following values for osteopenia, osteoporosis, and severe osteoporosis. Historically, the guidelines for the management of osteoporosis were based primarily on BMD T-score alone. The Fracture Risk Assessment Tool, or the FRAX, released by the WHO, helps in determining which patients may be candidates for pharmacologic therapy. This estimates the 10-year probability of a hip fracture and the major osteoporotic fracture of the hip, spine, humerus, and wrist. The calculation for fracture risk is country-specific. The probability is calculated using clinical risk factors alone or in combination with BMD measurement of the femoral neck to improve fracture risk prediction. A recent cross-sectional study published in 2021 was designed to estimate the appropriate intervention threshold for the Philippine FRAX model. 3 intervention thresholds were studied, and based on their results, they recommend using age-dependent thresholds for ages 70 and above and hybrid thresholds for those under 70 years old. Based on the 2020 clinical practice guidelines, it is recommended that postmenopausal women meeting the following criteria should be considered for pharmacologic treatment: a diagnosis of osteoporosis with a T-score of less than -2.5, the presence of a fragility fracture regardless of the BMD, a diagnosis of osteopenia plus a fragility fracture, or osteopenia plus a high FRAX score. For Philippine FRAX, this is more than 1% for the hip and more than 3% for major osteoporotic fracture for ages under 70 years old, and more than 1.8 to 3% for the hip and more than 6.3 to 6.9% for major osteoporotic fracture for ages 70 and above. These are the 3 strategies in the treatment of postmenopausal osteoporosis. Fall and bone loss prevention can be done by improving the modifiable risk factors within the patient and their environment. Exercise focusing on improving the balance and weight bearing were seen to be beneficial in the older population. The American Heart Association and American College of Sports Medicine advises to accumulate 30-60 minutes of moderate intensity aerobics or 20-30 minutes of vigorous intensity aerobics per day. Vitamin D supplementation should be around 1,000 to 2,000 IU per day to be able to maintain serum levels of at least 30 nanograms per milliliter. Calcium intake via diet plus supplementation should be around 1,200 milligrams per day. And protein intake should be around 1 to 1.2 grams per kilogram body weight per day. Pharmacologic treatments aim towards prevention of osteoclasis via estrogen replacement, anti-resortives, and via anabolic agents. The American Association of Clinical Endocrinologists recommends that the initial therapy be either alendronate, risedronate, zoledronate, or denosumab. They do not recommend concomitant use of these agents. The following are medications locally available that can be used to treat postmenopausal osteoporosis. Shown in the table are their effects on the occurrence of new vertebral, hip, or non-vertebral fractures, recommended dosage and route, duration of treatment, and adverse events. Monitoring can be done via repeat DEXA scans every 1 to 2 years until stable. Bone turnover markers, if available, may also be used to assess for treatment response. And reevaluation should be done after 3 to 5 years of treatment. A treatment is considered successful when there is stable or increasing BMD in DEXA scans and there are no evidence of new fractures. Treatment compliance usually diminishes over the first 2 years, and these are caused by financial limitations, fear of side effects, and a lack of perceived need for an anti-osteoporosis treatment. During the COVID-19 pandemic, countries have implemented a series of unprecedented measures to mitigate the spread of the virus. This introduced challenges in the management of many chronic medical conditions, including postmenopausal osteoporosis. The pandemic caused delay in the treatment dosages due to limited access, and there were significant reduction with regards to assessment of fracture risk in osteoporosis. Due to difficulty in logistics, postponement in the lab monitoring and BMD examination may be done, and fracture risk assessment may be done remotely via FRAX alone. Similar recommendations were given with regards to continuing medical management of osteoporosis. Because of its high affinity to hydroxyapatite and a very long half-life, Bisphosphonates can be delayed for several months. For teriparatide, some anti-fracture efficacy can be maintained for up to 18 months after discontinuation. Some studies show that regimens of cyclic treatments of 3 months on, 3 months off for 4 years showed similar increases in BMD compared with the standard daily treatment for 2 years. There is evidence that delaying denosumab treatment can cause a rebound increase in bone turnover. Some reports have seen new vertebral fractures as early as 7 months after cessation. Therefore, shifting to an oral bisphosphonate is recommended at this time. Romosozumab delay of more than 3 months can also increase bone turnover. Hence, it must also be followed by an oral bisphosphonate after 2 months. In summary, all postmenopausal women should be screened for postmenopausal osteoporosis. Fracture risk assessment is important, and this can be done via FRAX tool with or without BMD assessment. A fragility fracture can increase mortality and lower the quality of life, hence we aim for prevention of this dreaded complication. The benefit of anti-osteoporosis treatment greatly outweighs its risk. They reduce the morbidity and mortality and have a long-term safety profile. It is our duty as physicians to educate our patients and give them options which can be sustained financially in the long term. These are my references. Thank you for listening.
A warm welcome. Thank you for joining this symposium. This 71-year-old male consulted via telemedicine for mechanical back pain unloading the spine with difficulty in ambulating after a fall. No deficits reported, and X-ray showed multiple compression deformities. Additional tests were done 2 weeks later due to logistical challenges brought by the pandemic restrictions. Abnormal marrow changes on L1 and T11 vertebrae indicated acute compression. No marrow changes on L2 and L3. Bracing advised, pain medications, bisphosphonates, calcium, and vitamin D started, with supplemental vitamin D to correct his deficiency. Calcitonin given for 2 weeks and close monitoring advised. Osteoporosis, a worldwide public health concern, leads to decreased bone strength, increasing the risk of sustaining fractures. Osteoporosis affects over 200 million people, and with increased life expectancy, incidence of osteoporotic fractures increased, affecting both men and women, with the risk of refracture greatest in the months following the first fracture. Timely assessment and rapid treatment to prevent further fracture is essential. Vertebral fracture is the most common type of osteoporotic fracture. OVF is associated with decreased survival, may lead to back pain, deformity, and impaired quality of life. OVFs result to an increased risk in subsequent fracture, pulmonary-related complications, and increased mortality. Conservative treatment for acute OVF is considered the primary treatment option. Surgical intervention is advised in patients with unstable fractures, continued back pain, pseudoarthrosis, and severely collapsed vertebra leading to neurological deficit and kyphosis. Acute pain from a new OVF usually resolves within 6 to 12 weeks. Therefore, non-operative management focuses on pain relief. It is a combination of brace use, analgesics, and osteoporosis medications with regular radiologic monitoring to detect displacement, malunion, or non-union. This treatment plan was applied to our index patient. First-line treatment for pain management is through analgesics, using an incremental approach to the choice of drug. Anti-osteoporotic drugs may be used for pain control and decrease the chance of future vertebral fractures. Teriparatide reduces the risk of subsequent fractures while increasing bone density. Spinal orthosis reduces pain, but has disadvantages like reduced pulmonary capacity, poor compliance, and muscle weakening. Once acute pain is better, consider strengthening and balancing exercises. Although most OVFs heal well, impaired fracture healing may result in complications strongly related to poor prognosis, prolonged back pain with negative effect on the quality of life. Identify risk factors in failure of conservative treatment. Older patients, severe osteoporosis, obesity, frailty, and the presence of IVFs are more likely to fail conservative treatment. Risk factors include SEP and middle column involvement. Neurologic impairment is related to bony retropulsion. If prognosis can be predicted at the early stage, more aggressive treatment may be considered to avoid complications. Less than 20% may have delayed union at 6 months. There is no universal criterion for the diagnosis of non-union after OVF. A gas-filled or fluid-filled cleft is often seen in non-union. Research shows that dynamic X-rays are unable to accurately predict fusion outcomes, and bony union is better assessed with CT, but dynamic X-rays are unable to accurately predict fusion outcomes, and bony union is better assessed with CT, but has high radiation doses. Identify risk factors with close monitoring during the conservative treatment for at least 3 weeks. And if poor prognosis is predicted at the early stage, more aggressive treatment might be considered. Repeat X-ray and observe for further collapse or new deformities. Dynamic X-ray helps determine stability and non-union. A whole spine standing X-ray assesses the spinal alignment and sagittal balance, while your MRI checks for signs of edema, differentiating acute and chronic deformities, and confirms non-union of fractures and the presence of fluid, which points to poorer prognosis. For this patient, consider a bone-forming agent if there are no contraindications. Determine the pain source and characteristics. Identify risk factors for failure of conservative management. And for this patient, risk factors include his older age, low T-score, and involvement of the thoracolumbar junction. Due to the persistent mechanical pain, operative management was offered for this patient later on. He was largely hesitant to come for any procedures due to the pandemic. Vertebral augmentation is usually offered to patients who do not respond to conservative management and is most effective within a few weeks of fracture. VA has its advantages and disadvantages, and when this is offered, patients should be fully informed. Low complication rates are generally reported, with moderate quality evidence noting the risk of serious side effects. Cement extravasation has a low rate of symptomatic leakage in BKP, and to reduce the risk of cement leakage, the following techniques can be employed. COVID pandemic has affected our delivery of healthcare with significant decrease in elective surgeries, and focus was on controlling the pandemic. COVID aggravates osteoporosis, especially with the lockdown imposed on the seniors because of the disruption of osteoporotic management and limited movement. During the pandemic, we saw a decline in high energy injuries but continued to encounter fragility fractures. There were more fractures occurring at home with a higher proportion of low energy injuries. Hip and spine fractures in the elderly are associated with increased mortality, reduced quality of life, and functional limitations, along with the economic burden to the health sector, which further compromises the COVID-related treatment. In elderly patients with several comorbidities, the infection may be complicated by ARDS with high risk of death. The presence of VF negatively influences the respiratory function of the patients. Thoracic VFs are a good marker of patient fragility and poor prognosis, suggesting that morphometric vertebral X-ray evaluation should be performed in all patients with suspected COVID. Osteoporosis-related fractures, especially in the elderly, pose a real challenge for appropriate management during the COVID pandemic. With lockdown, access to healthcare was limited with services suspended. We relied on history-taking and clinical prediction tools for assessing osteoporosis risk, and X-rays are helpful in recognizing osteoporosis, while OVFs can be identified with vertebral morphometry. Prevention and management of osteoporosis are the key elements in managing OVFs. Continue the general management while considering side effects of meds, difficulty in getting workup, and the supply chain. Bisphosphonates and teriparatide are mainstay medications for improving fracture healing in OVF. Consider shifting medications if compliance is an issue. Home visits and telemedicine can be done to provide instructions and education to patients. Continue awareness for osteoporosis and continue management even if tests are limited. Calcium, vitamin D, and bisphosphonate therapy remain the cornerstone. Follow-up and patient education through telemedicine whenever possible, and surgery is reserved for exceptional cases and performed under strict safety precautions. We are witnessing an increase in OVFs as the population is getting older, and COVID has negatively affected this age group. Low energy injuries may result in acute OVFs with pain resolving within a few weeks, maximizing conservative management. Risk factors in the failure of conservative management should be recognized early and be treated aggressively. The pandemic affected healthcare access and delivery and made us re-strategize the management of fragility fractures in general. Remote technologies like telemedicine are maximized in treating patients. Luckily, most OVFs have little role for surgical intervention, and these patients should be managed conservatively with close monitoring, preserving surgical intervention while exercising strict safety precautions. Thank you for listening. These are my references.
Hi, good afternoon, everyone. Today I've been invited to speak on the delayed management of osteoporotic vertebral compression fractures. I have no disclosures. So osteoporotic vertebral compression fractures, or OVCFs, are the most common complication of osteoporosis. More than two-thirds of patients are asymptomatic and diagnosed incidentally. Patients with an acute fracture may report abrupt onset of pain, even with just position changes, coughing, sneezing, or lifting. NPE findings are often normal but may demonstrate kyphosis and midline spinous tenderness. Chronic OVCFs may present with chronic pain and loss of height, in addition to progressive kyphosis. So today's discussion will focus on the options for management of chronic OVCFs under the assumption that the treatment implementation was delayed due to one reason or another. There are many factors that may contribute to significant delays in the diagnosis of OVCFs. Most commonly, there's failure on the patient's part to seek immediate medical consult, which may be due to physical, financial, or other reasons. Other factors include the availability of imaging techniques in their respective areas and the lack of or differences in diagnostic protocols. Etiology or cause of the injury may also be a factor, especially if there is no actual precedent trauma. So often, patients will believe it to be just regular back pain that will go off on its own, or they may be diagnosed with a simple muscle strain, and as such, initial radiographs are not always requested, and the fracture may be missed. And of course, unforeseen circumstances can always happen that prevent patients from seeking consult, such as the recent occurrence of a global pandemic. So acute pain from a new OVCF usually resolves within 6 to 12 weeks. Conservative treatment is considered the primary option, especially in medically underserved areas and low to middle income settings. It focuses on pain relief through short-term bed rest, analgesics, anti-osteoporotic drugs, physiotherapy, and bracing. Now, depending on the timing of the patient's first consult and once necessary imaging studies have been done, it is important to observe the following. Is the patient still in severe pain? Is the patient unable to maintain an upright position despite assistance or medications? Is there severe deformity clinically or severe vertebral collapse on imaging? And does the patient have any neurologic deficits? So if any of those questions are still answerable by yes at 12 weeks post-injury, then any further attempts at conservative treatment may no longer have any significant effect. Now, the two most established vertebral augmentation procedures utilized in the treatment of spinal compression fractures are vertebroplasty and kyphoplasty as described. The question is there still a use for either procedure in the treatment of chronic OVCFs? So studies such as that of Kaufman noted that patient selection for vertebroplasty is not based on the actual age of the OVCF, but largely on evidence of non-healing on bone scan or MRI and the degree of persistent pain. Additionally, according to Brown et al., most patients with fractures more than 1 year old may still experience clinical benefit from vertebroplasty, but complete relief of pain is more likely when less mature fractures are treated. On the other hand, nearly all studies done on balloon kyphoplasty have demonstrated better clinical and radiological outcomes when the procedure was done in the acute setting. So a study by Park et al. In 2010 noted that patients who undergo early BKP of less than 4 weeks demonstrate better alignment, better low back pain scores, and reduced rates of subsequent fracture at an average of 1.2 years. Furthermore, Minamide in 2018 demonstrated that achievable correction of the fracture-related local kyphosis decreases significantly after 6 weeks. However, both procedures have been found to be effective for documented pseudoarthrosis and Kumel's disease. So in short, both vertebroplasty and kyphoplasty produce better results in the acute setting, but both can still be utilized in the presence of non-union and persistent pain, for as long as the collapse or deformity is not severe and there are no neurologic deficits. Now, although most OVCFs heal well, approximately 15 to 35% of patients can develop complications requiring surgery. So surgery then is advised for patients with unstable fractures, continued intractable back pain, chronic pseudoarthrosis, neurological deficits, and severely collapsed vertebra that can lead to severe kyphosis and its sequelae, like muscle weakness, pressure sores, impaired respiratory function, and delayed spinal cord compression. A study by Watanabe et al. Evaluated 5 typical surgical fusion techniques that have been used to classically treat OVCFs as enumerated. So it's the largest multi-center case series evaluating the surgical options for OVCFs in the thoracolumbar junction. So all 5 procedures were found to have resulted in acceptable neurological restoration and functional improvement in walking ability. Complication rates, prevalence of instrumentation-related mechanical failure, and subsequent vertebral fracture were also similar. So let's go through each one quickly. Anterior spinal fusion, or ASF alone, was performed using a rod or plate system with an iliac or rib bone strut graft or metal cage. Advantages are listed as follows. The ASF group demonstrated lower recovery rate of the JOA score and tended to have a higher incidence of mechanical failure at 26.3%. The procedure also had potential risk of additional posterior reinforcement in cases with very low bone density or multi-level OVCFs due to poorer stability of the anterior vertebral screw constructs. Posterior spinal fusion, or PSF alone, was performed using a pedicle screw and rod system, occasionally using laminar hooks in the upper or lowermost instrumented vertebra. Some reports demonstrated good clinical outcomes even without neural decompression, suggesting that the primary pathogenesis was instability of the fracture site rather than actual neural compression. However, it was found that the PSF group demonstrated a smaller degree of kyphosis correction, and in situ PSF alone was suitable only for patients with a mild to moderate magnitude of kyphotic deformity. Combined anterior and posterior spinal fusion provided an optimal biomechanical construct with an anterior strut graft and posterior screw fixation. Advantages include kyphosis correction and direct decompression through the anterior approach. However, there are potential risks of pulmonary compromise associated with the thoracotomy approach, especially for medically compromised elderly patients. The APSF group demonstrated a larger degree of kyphosis correction, but it also had the longest mean operating time and higher intraoperative blood loss. The 3-column osteotomy procedure consisted of a posterior spinal fusion and vertebral column resection with reconstruction using a metal cage, or eggshell shortening osteotomy through the posterior approach alone. While being able to achieve a larger kyphosis correction with direct decompression, its main disadvantage is that it is one of the most invasive procedures because of the resection of both posterior and anterior columns, and thus it carries a higher risk of neural tissue damage. Finally, vertebroplasty with posterior spinal fusion, which is widely used for OVCF patients with neurological symptoms, based on the consensus that spinal stabilization rather than neural decompression is essential. In fact, a prospective multi-center study by Katsumi et al. Reported that vertebroplasty with PSF without neural decompression can be used for patients whose canal contains less than 40% retropulsed bony fragments. It had a significantly shorter operation time and less blood loss, with shorter fused segments, and therefore can be widely used as a standard procedure for OVCF patients, even with neurological symptoms, although the ability to correct kyphosis is limited. Now, given that perioperative complications and implant failures have been observed in 18.1 and 41.2% of cases respectively, specific strategies for OVCF are needed. Inasmuch as I'd like to enumerate all the surgical strategies for osteoporotic spine fixation, due to time constraints, I will just leave you with these overall guidelines. So several authors have suggested numerous techniques for improving surgical outcomes and reducing the risk of complications in OVCFs, including the use of bicortical screws, cross-linking, varied fixation equipment such as laminar hooks, cement-augmented or expanding screws, interbody spacers or cages, transverse connectors, and other modified screw designs and trajectories. Hu et al. Also suggested additional guidelines to contribute to construct rigidity, such as avoidance of ending the instrumentation within the kyphotic segment to prevent screw loosening and junctional kyphosis, and acceptance of an incomplete correction of deformity to prevent hardware pullout from excessive corrective forces. Finally, as always, restoration of the lumbar lordosis and correction of sagittal balance without stressing the junctions is of utmost importance. Prevention and management of osteoporosis itself is one of the key elements in managing OVCFs. To reduce the risk of subsequent vertebral fractures, baseline drugs, classical drugs, and the newer agents as listed above may be administered. Important also is the medical management for fracture healing. Some authors have suggested that bisphosphonates suppress osteoclast activity and can hinder bone remodeling and maturation. However, a randomized trial by Nagahama showed that bisphosphonate treatment led to a significantly increased interbody fusion rate at 1 year. On the other hand, administration of teriparatide has been found to induce bone formation, and a retrospective comparative study with bisphosphonate by Iwata in 2017 showed a significantly higher union rate at 6 months in the teriparatide group, suggesting that teriparatide could actually enhance fracture healing in OVCFs. So in summary, with an aging population, the orthopedic surgeon must appreciate the effects of osteoporosis on the spine. There is an obvious lack of standard management strategies for OVCFs, and thus treatment should be tailored to each specific patient, depending on the clinical and radiologic findings, the timing of consult, the degree of osteoporosis, and the presence of other comorbidities. And when performing reconstructive spinal surgery in the elderly patient, the surgeon must consider the fragility of osteoporotic bone, the stability of the spine, and potential failure mechanisms of any applied instrumentation. Thank you very much.
Thank you for the lectures. We are now opening the
Good afternoon. I am
floor for questions to our
Thank you for this opportunity. I am a graduate of St. Luke's Medical Center and a hip and knee replacement specialist. In the case, we will get opinions from various panelists on each case. The outbreak of COVID-19 was declared a pandemic by the World Health Organization on March 11, 2020. Many countries, including the Philippines, have implemented lockdown, and its impact has greatly affected the management of osteoporotic fragility fractures of the hip. Jose B. Lingad Memorial General Hospital was designated as a primary referral center for moderate to severe cases in Region 3. This was our hospital operations last year. From doing around 15 cases a day, surgeries were suspended for about 4 months and limited to 2 to 4 cases per day for the rest of the year. Suspension of surgical intervention of non-emergency cases, closure of outpatient clinics, and constantly changing protocols resulted in the neglect of fragility hip fractures and difficulty in their management. This was our census for fragility hip fractures for 1 year. Out of the 36 cases, 10 underwent surgeries, 26 were either lost to follow-up or treated conservatively. And as you can see, most of the cases were treated with hip arthroplasty and intramedullary nailing using proximal femoral nail, and average time from injury to surgery is around 90 days. Here are some of the cases. I will show you the history and preoperative x-rays, and there will be an allotted time to react after every case presented. For our first case, HM, an 81-year-old female, home ambulator hypertensive with kidney disease, with 3 weeks history of fall from standing height and landed on the left hip. Hip is externally rotated with leg length discrepancy of 1.5 cm. This is the injury film of the left hip, showing a 3-part intertrochanteric fracture with involvement of the lesser trochanter. So what's her plan? Are you going to offer conservative treatment or fixation? What kind of implant? Or will you replace? If so, will it be partial or total hip replacement? Will you use cemented or cementless component?
Dr. Miranda, can we have your management
Good afternoon,
for the
Amina.
Yes. Hi.
Hi, and
Good
good
to see
afternoon to my
you.
colleagues. Yeah, so as Dr. Bertel said earlier, we don't really know why we are here. We are deemed experts, but we don't see ourselves as such. But let me give my insight on the case. I see here a picture of, a comminuted unstable intertrochanteric fracture, as obvious, probably Evans Jensen unstable kind. And it seems to be with only 3 weeks post injury into the scene, it seems to be amenable to some traction and possible reduction. So I would opt for proximal femoral nailing. And I hope Diane agrees with that. It seems like there is sufficient bone stock as well for purchase of the lag screw. Okay, so that's my take there, Amina. Thank you.
Thank you, Joyce. Can we have Dr. Adele's inputs on the case?
Hi, Amina, and hello everyone to all the participants and speakers. Can I just say I concur with Dr. Joyce? No. um, it's 3 weeks old. It's unstable. If the patient is clearable by internal medicine and is not COVID positive, yes, I will do surgery, use a femoral nail as well. I will probably ask for a long film of the entire femur since the patient is 81 years old. So I will look at the bow. If it's not too if it's not too much, if it's acceptable, I will probably use the longest PFN, not the standard, so that it's more stable and I will be more confident in letting the patient wait there because it's going to be very hard to do partial or non-weight bearing for an 81-year-old patient. Thank you.
Thank you for that, Adele. So, ikaw na, Dr. Roberts. Ano pong insights mo sa kaso?
Okay, I'm not gonna cheat by saying I agree, but I really do. Okay, so it's an unstable, it's an unstable intertroch, and you wanna, I would fix because you wanna fix the medial calcar, right? But I would go old school then. I would do a second gen nail. I would do an intermedullary nail only because I'm old school that way. But yes, fixation pa rin. Fix all the way to the head, fix the head to the shaft, and mobilize the patient as soon as possible.
Thank you. Let us now continue with what Dr. Docena did.
Happy to give you this lecture on acute back pain. And
Let's ask our panelists. Thank you to our panelists. This is what we actually did. Patient underwent open reduction internal fixation using PFN. They had great difficulty during surgery due to the complexity of the fracture and porosity of the bone. These are the X-rays on AP and lateral view, showing reduction of the fracture with intact placement of the implant and shortening of about 1.5 centimeter. On the left are the intraoperative pictures and on your right is the follow-up X-ray at 3 months. There is still a 1.5 centimeter leg length discrepancy. We opted to delay the weight-bearing status during rehabilitation until with signs of callus formation. Personally, I could have offered a bipolar hip replacement cemented using a calcar replacing stem with circlage wiring to allow immediate weight bearing and rehabilitation. For our second case, it's almost the same case as the first one. This one is a 73-year-old female, hypertensive with 5 weeks history of fall. On physical examination, she has a shortened and external rotated leg. These are the injury films in the AP and lateral view, showing a left hip intertrochanteric fracture with the involvement of the lesser trochanter. These are the x-rays upon follow-up at 5 weeks, showing callus formation with leg length discrepancy of almost 2 cm. We are now at 5 weeks post-injury, and we actually have 6 weeks delayed surgical scheduling. So earliest for the patient to be operated on is at 3 months post-injury. To the panelists, same questions for the second case. What are your plans? Are you gonna treat the case conservatively, or are you gonna fix? If so, what kind of implant? Will you offer hip replacement? Will it be partial or total hip replacement? And what are your components? Will it be cemented or cementless component?
Can we start off with you?
I have a question. Does the patient, because it's 5 weeks, does the patient still have pain on presentation?
Minimal pain na lang, Doktora.
Minimal pain, more or less acceptable alignment. I will probably do a trial kasi nag 5 weeks na siya ng conservative treatment. I will probably ask her to continue or suggest to continue conservative treatment. If it continues to, the patient continues to have, or if the pain continues to lessen and eventually, and then do a repeat x-ray after on the 8th week and then go from there. Thank you.
We will now continue with Dr. Jan. Can we have your insights on the case?
Thanks, Amina. Hi, Diane. This actually sounds like one of my one or three of my patients, like elderly and lalo na delayed yung actual scheduling that you can do. And at 3 months, we all know that that is part of conservative treatment. We just actually tell them to mobilize them, sit them up, if they can actually stand with a walker until 3 months. And we've seen patients improve and are able to actually walk and ambulate on fractures like these. These are almost, you can correct me, they're almost stable enough for them to stand on. So I would agree. If she's fine and you can't schedule her until 3 months anyway, I would just follow her up with the repeat X-rays at 2 months and on the 3rd month, and then decide again. If she's happy, she's up about and walking already at 3 months, and the X-rays are nice and stable, then no surgery for me.
Thank you, Doctor.
Thank you, Jan. Next, Joyce.
Yeah. So we have here a 73-year-old female who's been delayed for up to 3 months, right, Dr. Pangilinan? Yeah. So that is one of the things that we have to consider. We have delayed the surgery so much to a point that she developed callus already. So there is union happening now. So disturbing this union may not be beneficial to the patient as we would want it to be. A next point is there is minimal pain, as said by Dr. Dayan. And, operating on the patient is not a guarantee that we would lose the pain. So having minimal pain and possibly progressing to less painful state, even less painful state, would be a thing to work out on instead of surgery. And then still another point is that the limb length discrepancy is less than 2 centimeters, which is acceptable. It's so much acceptable. So there is a big chance for the patient to ambulate even with an assistive device. So with all things considered, I'd go for a conservative approach and not operate on the patient.
Thank you, Doctor.
Thank you, Joyce. Let us now continue with the lecture.
Okay, let's ask our panelists. Again, this is the X-ray. Upon follow-up at 5 weeks, there was evidence of some callus formation. Again, we had 6 weeks backlog on surgeries, so that will be around 3 months post-injury. Because of the delay in surgical scheduling, she opted to conservative treatment. This is her at 9 weeks post-injury, with X-ray showing callus formation at the fracture site, no pain on standing and ROMs. Although with 2 cm leg length discrepancy and a 40-degree externally rotated leg, patient and attending physician still opted to just treat it conservatively and started partial weight bearing. If he is not happy, we can still offer total hip replacement. Our last male hypertensive community ambulator complaining of right hip pain secondary to fall. She was initially seen at 4 months at the OPD and was offered surgery, but again, due to financial constraint, lockdown, and delay in surgical scheduling, she was admitted at 7 months post-injury. These are her x-rays taken on AP and lateral view showing a femoral neck fracture and arthritic hip joint. So to our panelists, we have the same questions for the third case.
I think nawala si Amina.
Yeah. So, tara, tayo na lang, Doktora.
Following her
Go.
questions kanina, Dr. Bertol, ikaw naman ang mauna.
Okay, I would offer total hip replacement for this patient. There's really no continuity between the neck and between the head and the shaft on this case.
Thank you. Thank you, Dr. Bertol. Yes, obviously, there's a vascular necrosis setting in, as would happen after a subcapital femoral neck fracture. And there is a more remarkable limb length discrepancy than the previous case. So, an erosion of the acetabulum as well. So, I would refer to Dr. Dayan for management of this patient, and she'd probably do a total hip replacement. What about you, Dr. Belen?
Well, even if I said mag-iba-iba tayo ng sagot para may pag-usapan, eh hindi pwedeng pag-usapan yan. So, I will
Kasi
also...
magmumukha kang ano.
hindi na...
mali.
So, I will offer total hip replacement because there's already hip arthritis. So that we can mobilize the patient right away and do physical therapy as well. So that's all. I don't know what else to say. Thank you, Diane. Back to you.
Thank you, Dr. Thank you to our panelists. So for the third case, a total hip arthroplasty was done, cemented on both acetabular and femoral component. Patient is currently ambulating with cane with 0.3 cm leg length discrepancy. In conclusion, COVID-19 lockdown has greatly affected the management of osteoporotic fragility fractures of the hip. Delayed surgical scheduling resulted in poor outcomes. Some become neglected, some lost to follow-up, some opted conservative treatment, some were changed to a more extensive surgical intervention, while others cause atrophy of muscles and decrease the strength of bone, therefore delaying rehabilitation. And even if we have different approaches in management of these cases, as orthopedic surgeons, it is our duty to provide the best quality of care and optimize both medical and surgical treatment for our patients. Thank you.
Thank you for that, Dr. Lucena. For now, to continue with the question and answer, do we have any questions for the first three speakers? for our set of lectures. So I will ask a question. For any of our lecturers can answer. During the pandemic, how did you encourage our patients to continue or to start treatment for osteoporosis? How did you encourage them to have physical activity? Dr. Rayel?
Hello, good afternoon, everyone. For my patients, I do counseling with them during their clinic consults. And with regards to the physical activity, since during the pandemic, we did have some limitation in the activities outdoors. Then I just advise them to do the exercises at home with supervision from their younger family members so that they won't have any lapse.
Thank you for that, Barbs. For Dr. Pebbles Ganal Antonio, among the osteoporosis medicines for osteoporosis, what did the patients have the most difficult time taking, or what medication did they find was the easiest to take, was the
So
easiest to be compliant with?
for during the pandemic, there was a difficulty in procuring evandronic acid. So there was some of my patients had to shift to alendronic acid. The ones who were currently on denosumab obviously had difficulty accessing also coming to the hospital. So for my patients, I would have home visits. So I would go visit talaga and give them every 6 months. No? Of course, it takes a lot of time, and you practice all these safety precautions. But if you're looking pre-pandemic, I would say I always still start with alendronic acid, given that it is a good standard, and I do warn them about the side effects that they may feel, especially the flu-like symptoms, which during the pandemic they have to stress because they might feel like joint pains and they may think it's related to COVID. And if they can't tolerate, then I would recommend that we shift to an injectable like denosumab. If a patient is severely osteoporotic, then I would encourage teriparatide. So it's more on if I look at the side effects, very minimal, really. They don't have a lot of difficulty, but compliance sometimes is an issue. So I always have to remind them gently that they have to make sure that they take it on time. Thank you, Amina,
for
for
that,
your question.
Pebbles. For Annex, among the surgical options that you gave for osteoporotic vertebral fractures, what was mostly done during the pandemic?
Fortunately, during the pandemic, I didn't have any actual, not for osteoporotic vertebral fractures. It was mostly for tumors, no. But I would say the most common is still the posterior fixation, and with or without the vertebral or kyphoplasty. Usually, you can use the cement fenestrated screws, as Dr. Leung suggested, especially if the bone is severely osteoporotic. No, but I usually the anterior surgery and the combined with the osteotomies and all is not as commonly done because they're quite large surgeries, and preferably you do them on the very, very severe deformities. So usually it's still the posterior, especially if you're still able to catch them at mild to moderate collapse.
Okay, thank you. So we have a question from the chat box. What advice do you give for premenopausal women who underwent Tabiso or Tahuso? Are they qualified to take alendronic acid aside from calcium? Thank you. Anyone can answer.
Tibbs.
May I answer. With regards to those patients that are premenopausal, who basically they're already surgically menopaused, they need to start on estrogen therapy basically. So those who are undergoing estrogen therapy may not need to start on bisphosphonates only with calcium supplementation, but you also need to coordinate this with their endocrinologist or their OB/GYN.
Thank you for that, Dr. Rayel. So if there are no other questions in the interest of time, um, we will end this lecture. But it is important to note that we should make our patients aware of osteoporosis and the possibility of fragility fractures, because this pose a very poor outcome for our patients. So again, thank you for attending our set of lectures, and congratulations to the present POA. Thank you.
Thank you very much.